intervention and prevention measures for individuals with cardiovascular disease or risk of disease. Therapeutic interventions for individuals with cardiovascular disease will be presented in this chapter and will also include therapeutic interventions to prevent cardiovascular disease, primary prevention. Information will be presented on the appropriate patient groups, including special considerations for each patient group, the setting where rehabilitation may be provided, the components and goals that should be considered in a rehabilitation, as well as the outcomes that should be measured, the administrative concerns involved in specific cardiac rehabilitation programs, and the justification for rehabilitation of these individuals. An important distinction needs to be made between rehabilitation of the patient with cardiovascular disorders and cardiac rehabilitation and a cardiac rehabilitation program, as there is a distinct difference in billing and reimbursement for cardiac rehabilitation programs in the outpatient setting. Cardiac rehabilitation and rehabilitation of the patient with cardiovascular disorders are synonymous and used in this chapter to discuss the interventions used for individuals with cardiac disease and dysfunction. A cardiac rehabilitation program in the outpatient setting is defined as a multidiscipline program of exercise, education, and lifestyle modification and is a covered service under the Centers for Medicare and Medicaid CMS and outlined in National Coverage Determination NCD, including a description of patient diagnosis, program components, etc. See the CMS page on the website of the US Department of Health and Human Services for NCD information. Individuals with cardiovascular disorders may be seen in a variety of outpatient settings for rehabilitation. However, if the individuals are referred specifically for a cardiac rehabilitation program, there are specific guidelines set that must be followed and specific billing practices that are implemented because of the standards set by CMS national coverage. Therefore, to prevent confusion in this chapter, cardiac rehabilitation programs will be the term used for the multidiscipline program and discussed later in this chapter. Interventions for individuals with cardiovascular disorders will be the main focus of this chapter. Primary prevention. Therapeutic interventions, including cardiac rehabilitation for individuals with cardiovascular disease, might not be necessary for many individuals if primary prevention of the disease existed. Active intervention for risk factors that cause cardiovascular disease. Therefore, primary prevention is an important component of wellness and rehabilitation programs that should be incorporated in all programs. Candidates for a primary prevention are those individuals who are at moderate or high risk of developing cardiovascular disease prior to manifestation of the disease, and those with family histories of cardiovascular disease. When presenting the need for primary prevention programs, one needs only to look at the statistics regarding the prevalence of modifiable risk factors in the current population. Cigarette smoking is the number one most preventable cause of disease, disability, and death in the United States today. More than half of all adult Americans have a blood cholesterol level higher than 200 mg per deciliter. One in four adults American has hypertension. In addition, there is a large proportion of the population in the United States that leads a sedentary lifestyle, despite the fact that epidemiological studies have demonstrated that regular physical activity protects against the development and progression of several chronic diseases. Obesity, identified as an important risk factor for both men and women, appears to interact with or amplify the effects of other risk factors, although the mechanisms are unknown. Obesity has increased during the past 20 years, and statistics that state that 47 million adult Americans are overweight, thereby making this risk factor a serious health problem. Primary prevention programs therefore have a large target audience. Two major problems inherent in a primary prevention program are compliance, especially long term, and lack of payment for services by medical insurance companies. Also, the expected outcome of a primary prevention program is a lack of manifestation of the disease, which is a difficult outcome to measure for an individual. This often creates a situation of denial or it won't happen to me attitude, which interferes with continual motivation and subsequently compliance. In addition, when medical insurance companies do not reimburse payment for services, individuals are likely to continue to pay for services. Therefore, similar statistics as reported in the fitness literature regarding compliance and long term commitment to diet, exercise training, and behavioral modification would be applicable to this population. Although research is somewhat limited in long term outcomes of primary prevention programs, scientific literature does support the reduction of risk factors as a result of primary prevention program. Risk factors that are identified by a primary prevention program include reduction of total cholesterol, high density lipoprotein HDL ratio, reduction in low density lipoprotein cholesterol, improvement in aerobic capacity and exercise tolerance, reduction in weight, reduction in resting blood pressure in hypertensive individuals, improved glucose tolerance and insulin sensitivity, improved feeling of well-being and improved tolerance to stressful situation. Box 18.1 presents the guidelines for risk assessment as determined by the American Heart Association's guidelines for primary prevention of cardiovascular disease. The specific components of a primary prevention program should include the following: therapeutic exercise to include development of an aerobic exercise prescription and possibly a resistance training exercise prescription. Dietary counseling for those with diabetes, weight management problems, and elevated cholesterol. Stress management or biofeedback. Smoking cessation. Pharmacological management for blood pressure, diabetes, or hypercholesterolemia. Education and self management techniques. The Guide to Physical Therapist Practice describes the patient group appropriate for primary intervention, risk reduction, or cardiovascular and pulmonary disorders in the practice pattern CA and includes detailed interventions to achieve the expected outcomes that will assist the individual in lowering his or her risk for cardiovascular and pulmonary disorders. Primary prevention programs should be implemented at the worksite, fitness centers, senior citizen centers, and primary physicians' offices, as well as in outpatient physical therapy clinics and cardiac rehabilitation centers. As most primary prevention programs are not reimbursed from medical insurance, individual fee for service or monthly payment plans may motivate more participation in these programs. Until the time that scientific and clinical outcomes demonstrate the efficacy of such programs, primary prevention probably will not be reimbursed under healthcare plans. Encouragement by primary physicians also increases involvement in a program. Centers that provide these services should therefore be documenting both short term and long term outcomes for possible inclusion in the medical insurance reimbursement plans in future. Rehabilitation of patients with documented cardiovascular disease. Individuals with documented cardiovascular disease benefit from therapeutic interventions to improve their aerobic capacity, functional mobility, or any other impairments, as well as to prevent progression of the disease, secondary prevention, or progression of impairments. The actual interventions used for their rehabilitation depend upon their specific impairments that are determined based upon the thorough examination of the patient using tests and measures, the prognosis and the plan of care previously discussed. The Interventions used include coordination and communication with other members of the patient's healthcare team, education instruction, and procedural interventions, guidelines for risk assessment, hypertension, physical activity, family history, alcohol or substance use, smoking history, stress, hostility, anger, diabetes, hypercholesterolemia, weight, other. Goals for prevention for primary interventions for primary prevention to prevent the harmful effects of prolonged bed rest when a patient is hospitalized with heart disease, to develop cardiovascular fitness with acute illness with emphasis on optimal ability for employment and leisure, to identify patients whose psychological response to cardiac disease may require extra support and additional measures for successful rehabilitation, to initiate a program of secondary prevention of cardiovascular disease aimed at reducing the risks of illness and death, as well as improving function and quality of life. To accomplish the preceding goals through interdisciplinary efforts directed at discovering each patient's optimal activity level, diet, and ability to improve unfavorable risk factors. Patient populations appropriate for rehabilitation may have primary cardiovascular disorder such as acute coronary syndrome, myocardial infarction, coronary artery bypass graft surgery, heart or heart lung transplant, heart valve repair or replacement surgery, congestive heart failure, or a secondary cardiovascular disorder such as history of coronary artery disease, CHF, MI, etc. And the therapeutic interventions used in their rehabilitation will be based upon impairments identified in the initial examination. Therefore, history taking via medical chart or interview with the patient is extremely important to uncover the secondary diagnosis of cardiovascular disease if the patient presents to the clinic with a primary neuromuscular, musculoskeletal, or integumentary disorder. Rehabilitation of the heart and lung transplant patient is discussed in great detail in chapter 12 and therefore will not be discussed in this chapter. Specific patient populations appropriate for cardiac rehabilitation outpatient programs will be discussed later in this chapter. Rehabilitation program. Rehabilitation of the patient with cardiovascular disease should be a multidisciplinary program of education, exercise, and behavioral change to assist individuals with cardiovascular disease in achieving optimal physical, psychological, and functional status within the limits of their disease. This type of rehabilitation includes the following: education of the patient and family in the recognition, prevention, and treatment of cardiovascular disease, amelioration of or a reduction of risk factors, dealing with psychological factors that influence recovery from the heart disease, structured progressive physical activity either in a rehabilitation setting or home program, vocational or return to leisure activities, counseling, activity of daily living, and functional training. Cardiac rehabilitation is typically organized in progressive phases of programming to meet the specific needs of individuals and their families in their stages of recovery. The acute or in hospital phase has been referred to as phase 1. The early outpatient or intensive monitoring has been referred to as phase 2. The training and maintenance phase has been known as phase 3, and phase 4 has been reserved for the high risk patients in a disease prevention program. The beginning in acute care. In 1952, Levine and Lawn demonstrated that early mobilization of the acute coronary patient to activity reduced complications and improved the mortality rate. Since then, physicians have increasingly realized the benefits of early rehabilitation measures. Physical conditioning can improve heart rate response, arterial blood pressure response in hypertensive individuals, myocardial oxygen uptake, and maximum cardiac output. In addition, improvements in the peripheral circulation, the pulmonary ventilation, and the autonomic nervous system benefit one's tolerance for work. Accompanying these physical improvements are greater emotional stability and self esteem. Early mobilization of stable individuals after a cardiac event has become a well established practice. The time course of care for coronary disease is changing dramatically owing to early diagnostic testing, new interventions, and the current managed care environment. Although rest is important to the impaired myocardium, optimal improvement of the patient requires redefinition of the degree and duration of rest. No longer is the patient lying in bed for weeks at a time. The average patient who undergoes coronary artery bypass surgery is ambulating on the unit by day 2 at the latest. After MI, patients are usually moved out of the intensive care unit and into the step down or telemetry until unit within 24 to 48 hours, and if uncomplicated, are often discharged 1 to 2 days later. Patients are no longer encouraged to seek alternative lifestyles or contemplate early retirements as a result of coronary disease. They are no longer spectators but rather active participants, and many become more active and healthier in life after a cardiac event than they were before. These are the three components of physical therapy interventions: coordination, communication, documentation, patient related instruction, procedural interventions. Therapeutic exercise, functional training in work, manual therapy techniques include mobilization, manipulation, prescription application, and as appropriate fabrication of devices, airway clearance techniques, integumentary repair and protective techniques, electrotherapeutic modalities, physical agents, and inaclinical modalities. Individuals who are not considered to be good candidates for rehabilitation are usually unstable and include the following: patients who have overt CHF, unstable angina pectoris, hemodynamic instability, serious arrhythmias, conduction defects, or impaired function of other organ systems. Patients who have uncontrolled hypertension, patients who have other disease or illness which precludes exercise, apparently healthy individuals. Mixing healthy individuals with persons who have heart disease may inhibit the former and frustrate the latter.